Hi, my name is Yin, and I'm going to talk about the second theme of our RPIW, which is related to the flow of referrals that require urgent or higher priority consultation with a psychiatrist. So pre-Kaizen, intake staff would have a weekly 1-hour scheduled meeting with a psychiatrist to review their urgent or higher priority consultations. And so, of course, this is an example of batching. And of course, there's issues related to that because the 1 hour was often not enough, and so cases would have to be carried forward to the next week, meaning that you'd have a lead time of potentially 7 days up to 2 weeks, 3 weeks, and so on. And so one of the fabulous ideas that our team had was to move from a weekly scheduled meeting to a daily scheduled meeting. And we discussed that with psychiatrists and had that implemented. Another fabulous idea was to have an and-on or some sort of signal for the psychiatrist to let intake staff know that they're available for other consultations, such as when they have a cancellation or a no-show. So we implemented that, and we actually had the IT folks come down and they installed MessagePal, our QHR's instant messaging system. And this is just a manual of how to use it. And although we had verbal agreement from our 3 psychiatrists, we also made sure that we want to make sure that they're able to read the standard work. And so we developed a training checklist so that, if they have any questions, we'll know. We want to make sure that everything's very clear. And post-Kaizen, instead of having those high batch referrals, we're now leveling the referrals, the consultations throughout the week.
Hi, my name is Amy, and I'm going to be talking about the referral form Kaizen. So pre-Kaizen, we did have a referral form, and many times this form would come back either incomplete, lacking important information, or sometimes even being sent on other documents. We also had a way to communicate back to the referral source, but this was often not used. It was only used in specific circumstances, so that loop was not always closed. So we identified some areas of difficulty with the process, including that the majority of referrals specified psychiatry services, suggesting that the referral sources weren't aware of all of the services offered by the clinic. Also, many referrals were being sent to the clinic that were not appropriate for our services, suggesting that the referral sources weren't aware of other community resources. So several idea sheets were created, including one on educating the GPs and referral sources on the use of forms. Also ensuring that referrals come to the clinic for the clinic to determine services rather than being sent for a specific service. Also around ruling out inappropriate referrals before the referral even gets to intake to process. So we did develop a new referral form, and this was based on a form used at Vancouver Island Health Authority. This form includes important components such as checkboxes and includes necessary information for the intake staff to ensure that they direct the client to appropriate services. Now, the backside of the form also includes a description of the services offered by the clinic and direction to a website to indicate other community options. And this form was trialed thanks to Dr. Blino. We also developed standard work around educating the GPs to engage them in the strategy and provide education regarding the use of the referral form. The new model of referrals is being sent to the clinic rather than being sent to a specific service and other services in the community. We also did develop letters to ensure that we close that feedback loop to the referral source so they know what happened with the client that they did refer. So post-Kaizen, we suspect that this will reduce the referral number to psychiatry, which was being referred to the most, and also that inappropriate referrals will be directed elsewhere.
I'm Candace. I'm going to speak to the fourth theme, which is the 5S of the file cabinet in the intake office. The pre-5S assessment was completed, and a score of 2.5 out of 5 was achieved with a goal of 50% improvement. The cabinet was located in the intake office, which was not accessible to all intake staff. Items for the day and items not in use were kept on top. The drawers were quite full with prospectus files, wait lists, bookings, old stats, and old phone messages. The prospectus files hadn't been cleaned out for approximately 6 months, which meant 18 months of prospectus being kept in there. The prospectus files have been thinned out and arranged into 1 year and 1 month prospectus. The file cabinet has been relocated and labeled appropriately, arranged for quick access of information by all intake workers. There has been a drawer assigned for daily work, which decreases the amount of files transported by intake workers each day. The offices were also cleaned out and arranged, and there also has been an area for a new safety door mapped out. The post-5S assessment showed an improvement in the area, scoring 3.3 out of 5.
I'm Tim, and I am going to present the newspaper this afternoon. I'm the sub-team lead for the RPIW number 2. The newspaper is an ongoing dialogue with the progress that you're making during the week. So the best part of this newspaper is we get to hand it off at the end of the week to the process owners. In the first page, we had documented a lot of the standard work that we were doing. So in the first page, we had a lot of the documentation completed again, and we've implemented. So we did some follow-up on those processes. Again, now we'll expect on our 30-day follow-up to make sure that we check in with the process owners so that that standard work stays in place. On the second page, we combined a little bit of standard work, some of the other themes. There's no particular order to these because they came up as we did on the week. So we combined in the training portion of that, and there was lots of training to be done for the changes in the processes that we did, and you've seen the forms up before. So we put into place the standard work with a training package for the psychiatrists, for the health record workers, for the intake workers, and again, we'll expect follow-up on that. So you'll see that as we go 25, 50, or 75% complete is our estimation of where we ended the process on this very short week and where we're handing it off to our process owners. The equipment installation as well. We had some good luck with the area to redesign it, but we didn't get a printer by the end of the week. Those things take a while to order in. We did get a hand-me-down file cabinet. We need to have some other equipment delivered later on, and we've left that with the process owners. They've signed off on all of that equipment, so we've made sure that the orders are in and the equipment is on the way. One of the big ones is doors, of course. So facilities will be having to knock out some drywall and put a door in, and that just doesn't happen overnight, and certainly not in our 3-day process. So I'll move on then to the target progress report, which is, again, Marlene had presented the baseline that we set and then the targets that we were going to follow. So the space requirement was reduced. When we changed the office configuration, the space actually required did decrease a little bit. Now we still need 3 workers, we still need space, and we still need to implement their safety. So we had a minor reduction of 10% or 9% up on the chart. The inventory, what we referred to there, was the batch referrals. Every Thursday for 1 hour, the intake workers would have access to a psychiatrist. They would have files piling up for weeks. In fact, Marlene and I started this at week -3. We only seen about 10, 15 minutes in that total time where the psychiatrist was available because of the many other duties that the psychiatrists do. So it was a high priority from our process and sponsors to make sure that the patients are getting the service. And for the patients to get the service, that's intake workers getting access to the psychiatrist. So we targeted that, and we put them in for 1 hour, and actually you see it up there right now. As a matter of fact, it is a high increase. We get anywhere from 20 minutes to an hour per day, depending on, again, on scheduling, but we'll try to process at least 20 people per day on urgent stuff. The part travel distance was the patient file. The lead time was reduced to 1 day because now instead of having to wait a week, we have just 1 day. Out calls in and moves. A lot of these are related to now the flow of the intake worker and how they have increased their time and availability to take more calls, to place more calls out, to gain the productivity in the other areas with the 5S and the setup and the cycle time that we've reduced.
Hi. I'm Fran, and I'm a client of the mental health clinic. This RPIW, in which I was very privileged to participate in, will ultimately affect the people who I represent. So here's a summary of what we accomplished during our workshop. Through restructuring of the intake area and 5S, we increased productivity, flow, and safety of intake workers. We shortened and streamlined intake and screening process. We had standard work for all staff involved in the intake process and better utilization of all staff. We moved to a daily consultation with psychiatrists, including instant messaging, and we implemented or are implementing a new GP referral form to mental health services, not psychiatry only. Now we would like to thank our sponsor, Michael, and our process owners, Lori and Dr. Natarajan, our psychiatrists, Dr. Isa, Dr. Kumar, and Dr. Reddy, especially the staff of the mental health clinic for their patience, support, and cooperation. Names are there. The IT staff, Randy and his team, the facilities, Ken, Verdell, and Daniel, and Dr. Blino from Family Medicine. And thank you, Sensei Shuno and Terry. We are all very happy, and we have learned a lot.